This conference will now be recorded.
Hi, welcome. It is Monday, June 20th. This is the Advanced Prostate Cancer Group of AnCan, and I'm Herb Geller moderating tonight, and I welcome you all. And I'll just catch Jim Marshall and George Rovder. Do you guys need some time tonight?
You
Jim
there,
or George?
Oh,
huh?
Yeah. Were you talking to me?
Yes, George, I'm talking to you or Jim Marshall.
Okay, I'll talk back. I just connected. Herb, I don't have anything today, but thank you for moderating.
Okay.
I really appreciate it.
Jim, do you have anything tonight?
Negative, Herb.
Okay.
Internet issues here. But
oh well,
I'm fine.
that's just too typical, right?
In the state of Florida, though.
Ah, okay. Well, who knows? There's other problems in Florida. Okay, we can begin. I guess early bird gets the worm. Carl, let's hear what's going on.
Okay. I wanted to initially defer to Rick. I know Rick, you wrote a beautiful note about Jerry Deans. So whether you want to talk about that now or later, but
oh my gosh. I'll gather some thoughts. It's still taking my breath away, as you can hear. So let me gather some thoughts, and maybe you'll come back to me, Herb, and I'll talk a little bit about Jerry. And if anybody else wants to drop in remarks about Jerry, I'll be sure that Patsy and the kids hear them. And I will say what I want to say a little bit sometime during the group.
Terrific.
I just wanted to say that the most impressive thing that I saw and that he had done, that right after having surgery from his hospital bed, he had joined us, and to show his he had brain surgery, and he showed the staples on his brain. And initially I was saying, I don't know if I want to see this, but it was just incredible how he had the lack of a better word, the guts to do something like that. But my understanding from what Rick wrote, he's made a tremendous impact upon many people and the prostate cancer realm overall. But anyway, back to me, I guess. I am having my next cabazitaxel carboplatin treatment this Wednesday, and it'll be number 7. I had blood work earlier today, and about a half hour ago I got results, and I wasn't too pleased. The specifically on the PSA, my PSA has again doubled in 3 weeks. So it has doubled to 18. It was 9 3 weeks ago. It was 4 3 weeks before that, and 2 3 weeks before that. So something that clearly there'll be a discussion about. I mean, the way my doctor has always said in the past, don't focus on the PSA, but he also had said in the past that when I had various treatment regimens and that the PSA accelerated over a several month period, he basically said, well, it's time to move on to something else. So I don't know if he will say that come Wednesday morning, but we'll see what the discussion is going to be. Also, with that combination, it does tend to affect the liver. My ALT is up to 50. I don't think that's still tremendously high, but it still is showing an indication that there is some effect on the liver from this treatment. And I don't look I'm looking for jaundice. I don't have any jaundice or any side effects that I know of liver issues. And the other thing is relating to the kidneys, that it could affect that. Not that I can say I'm having anything that I know of that's affecting the kidneys from this treatment. So I throw that out there. Should I, calm down or go with the flow? But at this point, it's concerning to me. It's concerning to Arlene, my wife, and so we have Wednesday when the appointment will be. At the previous appointment, Dr. Soraya had mentioned that they will be having the lutetium-177, the Pluvicto, when it starts getting rolled out. I know someone here said they were going to talk about Pluvicto, so I'm not quite sure if that might be my next option, but I know there have been some clinical trials that show that those who failed prior chemo, that the lutetium could be effective. So that's where I'm at.
Yeah, that is, it's unfortunate that it's rising, Carl. I mean, that's, it does say something on that we probably are not thrilled about.
So, Carl, I have an idea, and I think probably we know you're PSMA avid, so probably a radionuclide PSMA treatment is very much in line. But I wonder, and Len and Herb, this is a bit above my pay grade, or Ben, you guys may be able to throw some thoughts on this. I wonder if you can re-challenge a PARP inhibitor after chemotherapy, because there has been talk, and we have seen that you can re-challenge androgen blockers after chemo, and sometimes it works. We've had people that do that. And your BRCA is germline, so it's always there. Although I do remember that with Professor Bill, the mutation returned to wild type. I never really understood what that meant. I thought maybe it meant that these little BRCA mutations were now running around with bear hats on or something. But maybe Herb can explain to us what that exactly means when they say it returns to wild type.
It means
But
normal.
it might be worth.
It
It might be worth testing, and it might be worth seeing if one of the elaborate or one of the other PARPs would work for you again. Because how long have you been off the PARP inhibitor now, Carl?
It's probably about a year and a half.
Yeah. So go ahead, Herb.
No, I'm just addressing what return to wild type means. It means obviously that the clone that they're measuring, or the current state of the cancer, the tissue, it doesn't show the mutation anymore.
Okay.
Wild type is most of us. We are mostly wild type.
And that can be true even with germline?
No, it would be very rare for germline. It would have to only be somatic.
Well, because Bill was germline.
Yeah, I don't get that one. I mean,
Okay.
yes, it is possible if you have a germline mutation that the cancer clone could revert to wild type, but that seems pretty low probability event.
Len, any thoughts on rechallenging with a PARP inhibitor?
I think it's worth a try. Certainly worth a discussion with your oncologist. I'm sure they have a lot more experience than we do in rechallenging guys who have had a successful treatment with a PARP inhibitor and then relapsed, and then maybe a couple of years later, as in your case, they re-challenged, and it worked again. So certainly worth a discussion. I can't say that I recall any literature on this,
Right.
but if it were me, I'd definitely take up the conversation.
Yeah, I mean, it's still relatively new. The PARP inhibitors are relatively new. When I was on olaparib, they were still in clinical trials, and I was able to get what was that, off-limit use or
Off-label.
right, off-label use, and at the time, so I think still relatively new. And I haven't read anything as far as any other potential treatments outside of PARP inhibitors for BRCA2.
Right. The only other thing that might be worth noting, Carl, is that we've been having discussions about Pluvicto.
Right.
And there are ideas, and especially through Dr. E, that combinations of Pluvicto or another PSMA-directed radionucleotide plus something else may be more effective. I mean, and so it might be, and I know, I mean, you love clinical trials, so therefore that it might be worth thinking about something where you're guaranteed to get the PSMA lutetium in addition with accompanied with something else.
Okay.
Why is it?
Yeah, other than that, I mean, I was on a cruise a couple of days ago. It was only 5 days, 4 nights, and probably over 8. I'm sure that wouldn't have affected the PSA, but I had a relaxing time on the cruise. We went to Halifax, Nova Scotia.
And everybody tested negative?
Well, before you're allowed on the cruise, you have to have a PCR test within 48 hours prior to boarding. And you do have to show evidence of vaccination. Someone did tell us that they saw a black limo that came up to the dock as we were disembarking, and they rushed somebody into the limo and rushed them away, and they believed that that person had was positive for COVID. So they
Oh, jeez. Oh. Why are you reticent to do a PARP inhibitor again? How did it work? Why did you stop it in the first place?
It worked great. I mean, it worked for almost 2 years, and the PSA was undetectable for that time. And then it started to rise, and you know, it was a known fact that that's pretty much the time frame, year and 9 months to 2 years, that it would be effective, and that's exactly what it gave me.
So how long has it been since you stopped the PARP?
Yeah, about 1.5 years.
Okay, so that's why they're wondering if it might work again. What did you do in between? You just waited?
Oh, no, I kept going. I participated in several clinical trials that were very hopeful, but you know, it didn't work out. There were at least 2, if not maybe 3 clinical trials that I participated in, including the last one was with Dr. Scott Tagawa at Weill Cornell, and it was a triple therapy of actinium with Keytruda and enzalutamide. So, and although the Keytruda, I am not MSI, and I have a low tumor burden, which is typically the opposite of what would make Keytruda effective. And I had several times said that to Tagawa, and he says, well, we just don't know what the combination will result in, and that it could result in a potential cure, is what he said to me, and no other doctor has ever said that to me. So I figured, okay, well, with something like that, and it was on it for 24 weeks, and at the 24-week mark, I was due for my next infusion of Keytruda. I was waiting in the infusion room, and they said, oh, yeah, we're getting it ready. And then 2 minutes later, a nurse came in, and the doctor wants to see you. So went up to the doctor's office, says, you know, you're not having the Keytruda, you're off the trial. Your PSA has risen to 62 at that time. And so that's when I then went on to this combination chemo cabazitaxel and carboplatin, and one of which the suggestion of the group here that it could be a beneficial treatment. So I've had 6. I'm having this, may or may not have the 7th this Wednesday, and but the PSA has, as I mentioned earlier, has doubled over the last 3 weeks and doubled from 3 weeks before that. So the PSA is now 18, having been 9 before and 4 before and 2 before that. So
I mean, I think it's certainly, Carl, something you're going to want to discuss with your doc.
yep. Okay. Thank you.
Okay.
I just want to say that, Rick, I don't know whether it works or not, but that's a great suggestion. That's a really good thought.
Thank you.
Okay. Al Latimer, you have an update for us.
No, Al said he's not going to be back for 45
Oh, right.
minutes.
He's not going to be back for a while. Sorry. Okay. Joel, are you with us?
Yes, I am. And my PSA in April was, in May was had gone from April of 4.1 down to 3.7. But in June, it went back up to 4.9, which is the highest ever for me. And so I wrote to Dr. Antonarakis and said, should I be concerned about prostate cancer that stops expressing PSMA or prostate cancer that never expressed PSMA? And he answered me, no, you shouldn't be concerned about that at all. He says only MCRPC patients can the cancer do that. So he says you're still hormone sensitive, so don't worry about that issue. He said, I also had mentioned that should I take another somatic test, gene sequencing test? And he says, that's a good idea. He says, get one from Guardant 360 or Foundation One Medicine, get a CDX blood test, and we'll see how your cancer has morphed, because it's been 11 years since my biopsy sample of my first somatic test with Foundation One. I guess one of the questions I would have for you is, which one is better? He gave me 2 links, one for each site. He didn't give me a Caris link at all. So anyway, so he says, don't worry about your PSA going up and down. It'll do that. He says he didn't seem to be too concerned about the PSA. He says if it does go above 10, however, he says we'll consider a short course of ADT. And that's where he left it. I said, I asked him if we should have a face-to-face in Minnesota or in Maryland. He said, every month. And did you guys lose me or not?
Briefly, yes.
Okay. He says, just monitor your PSA every month and do a PSMA PET every year, and we'll continue monitoring the situation. So that's where I am with Dr. Antonarakis. Again, extremely helpful, extremely resourceful in what he has to tell me.
Yeah, wow, yes. He really seems to be very supportive and insightful.
So my input here, Joel, would be to do Foundation Medicine based on the fact that there are several of our GU medocs who don't like the Guardant test. Okay. So I would normally suggest either Foundation Medicine, Caris, or the one whose name I always forget that begins with a T, that's out of Florida. Can anybody help me, or do I have to do my research? I can come up with it in a second. But anyway, he didn't suggest that one. So I would definitely do foundation medicine, and I'm assuming he's talking about a blood test, because if he's including Guardant doesn't do tissue, I don't think.
Right. Okay. Joel, so any other questions for Joel or comments?
It's John. I have a question about those blood tests. Do they ever not find cells in the blood because the concentration is just too low, or the cancer is
Yes.
just not seeding into
Oh
the
yeah.
blood?
Oh yeah. I don't know if there's anybody on the call, but we've had that. It's a function of your tumor burden, and if your tumor burden is too low, there's a lot of times that there isn't enough. There aren't enough of these SNPs or whatever they are that are in the blood that they can collect and they can analyze these fractions of tumor tissue that slough off into the blood, and we've seen that. So normally you need a PSA. I'm stretching my mind, and maybe the other guys can help me, but I think you've got to have a PSA that's somewhere higher than around 3 or 4 to feel comfortable that you're going to get a decent result from blood, John.
But yes, it's true. I mean, if your tumor burden is low, they're not going to have any. They come out of CTCs, and it just doesn't. It's not there.
Right. Let me see if I can just give you the name of this company. I always forget it. It drives me nuts. It begins with a T. Tempus. 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 I'll put it in the chat window. If I write it down, it's better, then it sticks in my memory better. The good thing about Tempus is that they also analyze your RNA, but the thing about that is I'm not sure what that brings to the table for us. I don't think we know enough about RNA results right now, but I think we're starting to. And again, that's above my pay grade. I have to defer to the Brains Trust on that.
I mean, RNA would be very useful information, as would be certain kinds of proteins. I mean, because RNA is, when RNA changes in general, it means that some gene is over or under, is changing. And that would be worth knowing. Because the mutations are one thing, but then the level of gene expression is really, and the level of protein expression is actually what's controlling the behavior of the cell. So I think the more we can I really would like to see more RNA and protein measurements as time evolves. I think it's going to be overriding for it'll tell you about what the signaling is inside the cell.
Okay.
Anyhow, let's move on. Bob Snyder. What's doing with you?
Is Bob with us?
He is there. I see his.
Oh, you do see him.
I do see him, but he's muted and
His mic is muted.
Mike is muted. All right. Well, we'll pass that. We'll move on. Bob McHugh.
I'm here.
Tell us what.
Putting
tell
myself
us what's
back
up.
putting myself back on the air. After 3 years without treatment, and about a year ago, my PSA started to go up again very slowly. And in late April, it reached 0.5. My oncologist, Dr. O at Mount Sinai, who Lynn knows well, and some of you may, recommended a PYLARIFY scan. And so on May 12th, I had one. And it was advantageous. He gave me good advice because it lit up 3 small spots in my pelvic lymph nodes. bilaterally, 2 on one side, 1 on the other. Very small, but what one radiation oncologist referred to as hot, which is a term that I didn't really know. So it looks like I'm still doing my research. It looks like possible, likely more radiation. This would be my 3rd round. I'm a little concerned about that. And my 4th round of short-term ADT. I see, I've seen 2 radiation oncologists or talked to them, and their opinions are a little different. And last but not least, I'm seeing Dr. Geinesman at Fox Chase on Wednesday. Some of you, I think, know him. I think I actually got his name out of this group.
So
I'm still in the research phase.
So how did the radiation oncologists differ?
Well, you know something, Herb? They didn't differ all that much. The one radiation oncologist was at Mount Sinai. He was Dr. O's referral. And after talking to him, he expressed some concern in knowing exactly where I had been radiated previously, so that they would not re-radiate the same area. But ultimately, he said to me, I live in about 65 miles, 70 miles outside of New York. Ultimately, he said to me, go with the radiation oncologist who is closer. He's perfectly competent. And so really that was the difference, just the fact that he told me stay local. And it's I talked to that guy on Friday, and he suggested that, you know, somewhere in the neighborhood of 4 to 5 weeks of radiation might be possible. But again, he was concerned that these spots, although they're very small, less than half a centimeter, could be in areas that could cause side effect problems. And so he wants to do further research about the radiation that he gave me in 2016. The only other question, and I don't know the answer, and I don't know whether I needed your guys' opinion today, but I certainly will need your opinion eventually, is the radiologists both seem to think ADT may not be necessary, whereas the med onc, Dr. O, said from the start ADT would be necessary. So that's an open question.
Well, again, I mean, it's different specialty, right? Dr. O knows his medical oncology. He knows his drugs and what they're likely to do. And the radiologist like to do their thing.
Well, that's exactly what no less an authority than Len Sierra suggested, that these guys might be siloing a bit. I'll see Dr. Geinesman, who's a pretty well-respected GU med onc, on Wednesday. And so his opinion about ADT should be pretty, I should give it a fair amount of weight.
This is John. I have a question. Since probably your pelvis and prostate bed have already been radiated, why wouldn't they consider stereotactic radiation, just trying to shoot down those hot spots rather than doing the whole pelvis again? Is that just playing whack-a-mole? Because
maybe one of
the
maybe Rick or Len or Herb or somebody who knows more about this than I do. That was my first thought. There are 3 very discrete, tiny lesions, but they're bilateral, 2 on one side, 1 on the other side. And what Dr. Stock, Len knows who he is, he's a radiation oncologist at Mount Sinai, said, those are the ones we can see, but we would like to, it's probably wise for broader radiation, because there might be stuff in there that won't even show up with the Polarify scan.
Got it.
So especially at such a low PSA, right?
So that's logical.
So here's what I would say. I'm going to fall back on this recent research that just came out. What was it called? STOP or SMART, or I forget what it was called. I think it was called STOP, SSTOP. And it kind of confirmed that on recurrence, the best treatment is a combination of androgen deprivation therapy for at least 6 months and radiating the whole pelvic girdle. Now, that's something that we've said here for a long, long time. And frankly, it's based on Matt Roach, because that's always been his approach. And it's his approach if he's treating this disease, if you're a stage 3 patient like I was. So it's not, I'm not sure, and even from looking at my notes, Bob, whether you've ever had the whole pelvic girdle radiated. If you've only had the bed radiated or parts radiated, and it were me, I would do 6 months of ADT and get the whole pelvic girdle radiated, and hopefully that would nail it for a good while. But if you've already had the whole pelvic girdle radiated, then that's probably not an option. So that's what you've got to drill down on. I'm interested to hear what Joe Gallo has to say, because I know Joe is one person who's seen Gainesman, who sees Gainesman and has seen Gainesman. Joe, do you have anything to contribute?
Only to just confirm the feeling. He's quite capable and very, very intent, and he does interact both with the radoncs as well. So I'm pretty sure you get a good read from him. You know, he does his homework. Every time I see him, I pick up something new.
Rick, I don't want to take up too much more of the group's time, but addressing what you said, Rick, my first radiation, I believe, was of the entire pelvic girdle, 38 treatments of IMRT. And as you may recall, I've suffered some radiation cystitis symptoms ever since. Then later, my next reoccurrence was a very discrete patch about the size of a quarter in the prostate bed. Of course, the prostate gland was long gone, and they did stereotactic. And good news is the Polarify scan showed that that was effective because that cancer is gone. So,
So Bob, I'm going to go back to John's question, because if you had radiation cystitis and they're now considering more IMRT on the theory that there are some unknown lymph nodes that they can't see, it may be prudent to just do SBRT to those lymph nodes.
you know, Herb, I'm very worried about a third round of radiation because it's all in the same ballpark, and I've had problems ever since I had my first round. So, you know, I'm looking for either an alternative that doesn't include radiation, and I don't know whether such an alternative exists. But if it does, the one thing that the radiation oncologist down here suggested was, as a possibility, would be proton therapy.
Right.
Yeah, but I mean, I don't know enough. Maybe some of the other guys do here, especially the proton guys, to know that whether proton therapy is going to have a significant difference to the IMRT. I mean, I think the first thing you got to do, which is what your guy out in the boondocks is doing right now, is see what he radiated originally. Sometimes we have guys that do 38, and we find out that, you know, all they've done is the rabbit's ear, the rabbit's ear pattern of radiation, which is not the whole pelvic girdle. They've radiated the prostate bed and they've radiated the rabbit's ear, but they haven't radiated right across the pelvic girdle. So that's really the first question. When he did the original 38, what did he do? If the whole pelvic girdle has already been radiated, then I think that spot radiation is definitely a good option. And the other thing that unfortunately you got to consider, I hate to tell you, but it is hormone therapy, because we got to look at something systemic, and we can't use radiation, not the radiation as a systemic treatment, but the mildest form of systemic treatment is probably hormone therapy. I mean, if you really wanted to go in and nail it right now, you'd probably do, and the guidelines would suggest LHRH plus abiraterone. I mean, that's what they're doing now on recurrence to really nail it. So it becomes a negotiation with Dr. O as to how much to do. A lot of these
Is that an option without radiation, possibly?
Yes.
Yes, for sure.
Very
okay,
much.
Because I've had the Zoladex 3 times, and I've tolerated that pretty well, quite very well. So if there were an option that did not include radiation, that's something I'd really like to explore.
Yeah, I mean, I today would suggest Orgovyx, which is the pill form, relugolix, or Orgovyx, which is the pill form. If it were me, I'd probably ask for Orgovyx, and I'd try abiraterone with prednisone, which isn't.
Go ahead. I'm sorry.
No, which there's a lot of guys that have gone through that regime. There's somebody who joined us just a few minutes ago, they're a little late, who I know wants to talk about prednisone today. But I think that's probably what the standard of care would be. Len, what
Len's
would you say
computer
about
froze.
that?
Len's, I don't know if Len's with it. Len, are you still with us?
Rick?
Yes.
Rick, this is Joe. That is the therapy that I had. The relugolix and the abiraterone.
So I think the thing to do, Bob, is to talk to Dr. O seriously and say, is there a viable alternative to radiation?
Yeah, I mean, that's very much the question that I had in my mind coming into the group tonight. Rick, will you do me the small favor of sending me the name of those drugs offline?
Yeah, can I put them in the chat window to you?
Of course.
Yeah, okay. So yeah, I'm happy to suggest it and talk about that with Gainesman.
That's why I want to get the name of the drugs now.
Gainesman is my med-onc, okay? So he's very familiar with those.
Okay.
Right.
Well, thanks everybody. This is helpful.
Bob, this is John. This is John again with another question. It occurs to me as we talk that radiation therapy and hormone therapy are not two alternatives to do the same thing. They have different goals, and that may be why the two types of oncologists might differ sometimes. The goal of the radiation oncologist is to kill cancer cells dead. And the goal of the hormone therapy is to buy time. I don't know if it's useful to make that distinction in this case, but it just kind of occurred to me as something that it's a comparison of these two things that occurred to me. They're not the same.
Right.
Bob, this is Peter. Any good radiation oncologist, whether it's going to be proton or photon radiation, is going to carefully look at any previous radiation you've done, reports directly from the doctor with maps of exactly where they went, things that you don't have access to, and really look at it carefully to make sure that there's no overlap before they proceed or even consider it. I know my proton radiation guy looked very carefully at my 39 days of IMRT and stuff before he went on with any additional radiation for me. So I think a good radiation oncologist will be very thorough with that.
Yeah, I think my guy is competent, the guy that I'm talking to. And I may circle back to the guy at Mount Sinai, who Dr. O recommended, and say, this is what the radiation oncologist in Princeton is saying. Do you think this makes sense?
Good idea.
I'm not in any major rush to get, I have time. These are very, very small lesions, and you guys know how it goes.
Yep. Okay, Bob. Any other questions for Bob? So Peter, you started speaking. What's up? Tell us what's up with you.
Okay. Well, I met with Dr. Manuel Antonarakis this morning. Boots on the ground, face to face here in Minneapolis. And I agree with Joel Blanchett that this guy's really on his game. He's brilliant. And I was very, very impressed with him. I never met him before. I sent him all my records. I talked to a person who was gathering all the records, and he'd obviously plowed through 8 years of records and all my scans and genetic testing and everything. He knew me inside out, literally. Or at least, anyway, the insides anyway. Yeah, he had some interesting things to say. So one thing that I thought was interesting was there's no scientific proof of this or anything, but he kind of gave me the impression that in his feeling, his belief, the blood system and the lymph system were two different systems. And because, with a systemic disease, it doesn't necessarily mean that it's carried everywhere. And I have an unusual situation, which he acknowledged. In fact, he said that he's only seen in the Hopkins database 2 people, I think, with my profile in thousands of records. As Dr. Scholz says, I'm an outlier somewhat. 8 years in, no sign of bone mets, no sign of liver or any other major soft tissue stuff, just lymphatic spread. And as I mentioned, I think a couple of weeks ago, lo and behold, my PYLARIFY scan from the 31st, 3 weeks ago, is almost identical to the one 2.5 years ago that I did at Stanford, which just showed a couple of lymph nodes on my iliac area and left and right, and the pesky implants in my peritoneal area. So bottom line is, he says, I'm the perfect candidate for Keytruda, and it looks like we're going to start when I come back to Minnesota the first week in August, and I'm game for it. So I asked him if I should start on Maui. He said, no, let's just start right here. Probably be about a 6 months. I mean, I read online, they go up to 2 years. He said, no, he says in this situation, probably 6 months. He said, we're not going to go back on Lupron, but I'm going to stay on monotherapy darolutamide. He said it's fine. There's no reason not to stay on that. It's not going to hurt at all. And we talked about scans, and he said, later on, he said the scan's not going to show anything. It's really the PSA at this point. if we get mileage out of the Keytruda, it's going to show the PSA is going to go down, and we should know that in 2 or 3 months. So it'll be every 3 weeks, and yeah, I went out a happy camper. I'm very impressed with.
So does that mean you're going to have to be in Minnesota for the whole thing?
No, I can move it over to Hawaii when I go back in November, and he'll get in touch with my local doc there, Okazaki, and and Okazaki and Scholz and I and Turner, we've talked about Keytruda for some numerous years. I mean, his statement to me is, if I had been his patient, he would have started me on it several years ago, and not waited. But he says, likely we're going to get good mileage. I mean, I didn't quite get the whole thing, but he was reading things into the genetic testing that I didn't know. I mean, yes, I have an MSH6 gene mutation, but he said it's much more than that. He could see things in that genetic mutation that were very rare. He said he's only seen it twice in his database of guys with this kind of situation. So I'm going away optimistic and happy that I did this, and happy that I found him. So that's where I am. I asked him about Provenge, and he said no. He said he wouldn't do it at this time, and he just doesn't feel that's why wait? Why delay this anymore? He said, why go through that, and it's not going to particularly show any great additional promise, at this point. He said, no, let's go with the Keytruda. So
right.
That's where his thinking is, and I tend to be in agreement with him.
Any comments, questions for Peter?
So one thing for the group to understand that's really, really important here is that Peter is MSI high. And pembrolizumab, nivolumab, the anti-PD-L1s have a bucket approval now for people that are MSI high, meaning that is a suitable drug to treat somebody, whatever their cancer, if they show up as being MSI high, which means microsatellite instability high. And so that's why Peter says it's been on his radar for a long time, because his Caris test, which was back in July of 2020, reported that he was MSI high. So pembrolizumab is a very good drug, but it's not suitable for everybody. And that's one of the reasons why we say to people, if you're thinking about getting an anti-PD-L1, make sure that you've tested your MSI, because you're much more likely to respond if you're MSI high. Peter, you want to comment on that?
Yeah, I think that's very accurate. That's true. And I asked him about this MSK study that's going on. They got all the press about cure for colorectal cancer, and which if we read the fine print, it's not a cure for colorectal cancer. It's a cure, good results for people with Lynch syndrome and MSI high. It was a selective study, and he knew it well. He knows one of the primary investigators, and he said, no, it's not worth going that route. That's a different PDL inhibitor. But he said, even if it was open to prostate cancer, it's not worth going that way, because Keytruda is just as effective in my situation. And he gave me some insight, some of the backstory of that one. Anyway, but yeah, I think I'm a good candidate. As I say, I'm somewhat of an outlier, and I'm encouraged by hopefully get good results on
No,
this.
but we discussed.
Peter, this is Al. Did you get that test from Dr. Scholz? Is that where,
Yeah,
is that
it was
where it's done?
under Dr. Scholz and Dr. Turner's care when I did that.
Okay. Yeah, I did that same test and I was low. So Dr. Scholz told me Keytruda was not a good, I'm not a good candidate for Keytruda. So that's been off the table for me.
Oddly enough, my foundation medicine result from my was done on my my biopsy tissue. That came back as MSI stable. But the next time I was able to check tissue was 2.5 years ago when I did a biopsy of these things in my peritoneal, and that's the one that came back as MSI high.
Peter, you were the one who first alerted us to the ImmuDX test for detection of adverse reactions to Keytruda. Now, did you run that test recently?
No, I still have the old test that was run. I haven't done it again. He didn't indicate I should do that. He thought I'd probably tolerate it very well.
Okay. So the first time they did that test, it revealed that you should tolerate it well?
Yes, yes.
Well, that's great. Good luck.
Yeah. For those of you who are wondering what that is, that's a cheek swab test. I think we talked about it actually, strangely enough, last week, that will tell you how you will respond side effects to an anti-PD-1 or PD-L1 drug.
Oh, I misspoke. This is Al. I misspoke. That was the test I had with Dr. Scholz that said I would not do well with it. It wasn't the other. It wasn't the other test.
No, it wasn't the side effect test. It was basically probably the MSI test.
I think it was the side effects. There was the because I had this cheek swab. That's how. That's the test that I had. So Dr. Scholz does not have Keytruda on the table for me.
Okay. Actually, any more questions for Peter? Peter will be, I think you may, the time has come, so let's see how it works.
Yeah, so I just make one other comment about Dr. Antonarakis. As I said, I was very impressed with the guy. So, you know, as you intimated, you know, do I have to do this all in Minnesota? No, I'll be able to transfer it to Hawaii. And he said he will send his report and everything to Dr. Okazaki. And I said to him, will you also send the report to Dr. Scholz?
No.
And there was a pause.
Yeah.
A very significant pause there. And he said he would. He said he would. But I got the distinct impression that his assumption is that I'm moving over to his court. But I'm not ready to burn bridges yet. You know, as I talked to Susan here over dinner or lunch, that you know, I'm keeping the door open, and I'm not, you know, we'll see, you know, where it all goes and everything. But I'm not ready to fire one doctor and to hire another one right now. But I'm able to work with Dr. Antonarakis, and they have a beautiful setup here. I mean, the Masonic Cancer Center here at the University of Minnesota is looks like a pretty substantial modern establishment.
Just a quick question, Peter. I'm just wondering, with Dr. A, did AnCan come up, and did he?
Yes.
Was he familiar?
He knew us. He's never been on one of our calls. I did give him my card and mention you and some others. And I forgot to mention Joel Blanchett, but anyway, I did talk it up. And yeah.
Okay.
Great.
You know, it's so funny with not funny, but of course it doesn't surprise me with prostate oncology. I mean, long before most of you were even diagnosed, Dr. Scholz was around, and there were a couple of other doctors. There's a guy called, I think it was Lieberman or something like that, with something with an L, in Bob. Peter might remember his name.
I think it was Leibowitz.
Bob Leibowitz, thank you, Al. Bob Leibowitz and Snuffy Myers, who some of you may have heard of, and prostate oncology, Scholz and Turner, and at that time, if you mentioned the names of any of those guys to GU medical oncologists who were at centers of excellence, you were guaranteed to get a pause. Guaranteed. I mean, they did not want to work with them. And it was really interesting because Snuffy had these crazy ideas, and God bless him, he's still around. He doesn't practice. He has fairly advanced Parkinson's, I believe. But he had ideas that he was using, that we're embracing right now, that he was using back then. And probably the biggest one, and I'm going back to around 2009, 2010, was that hormone therapy must be used sequentially, that you don't use these drugs all together. Well, now we are. Now we'll use, we'll start a guy off on an LHRH drug and give him an androgen receptor blocker at the same time. And the studies have shown that's the most effective. But the only person that was doing what they called double blockade, triple blockade back in the day were the docs like Snuffy and Scholz and Leibowitz. Leibowitz was a little off the wall. I mean, Leibowitz was using hormone therapy to treat men with 3+3 cancer. So, which I always questioned. But Scholz and Snuffy were pretty legit, but they've never been accepted, as people like Peter will remembers.
Rick, this is Al. You know that I'm a Snuffy graduate, and 100% true. No, you almost wouldn't mention you knew Snuffy if you went somewhere else. It's just
so. Look,
just the way
I think we got it. We better move on. And Al, you're next.
Oh, okay. So I had my first Provenge round. I'm
going to
before
take
last.
a minute.
Can you hear me?
Yep.
So I had my first Provenge round the week before last. Things went okay, except, they have to they stick your right arm and your left arm. My right arm was not happy with it. They stuck it 3 times before they got it to work. So I've had a bruise on my arm for 2 weeks. But other than that, it went fine. I've experienced a little bit of fatigue from it. I had a couple of days with some mild headaches, but I don't know. That's about all I've experienced in terms of side effects. I had another PSMA PET last week. I'm waiting for the results on that. My PSA has gone up further. It's now 11. So since the end of the lutetium, my PSA has gone from 1.4 now to 11 since end of January. So it's rising rapidly. And we'll see what this PSMA PET comes up with. I guess I see the doctor later this week. So that's kind of the update. I had one other thing I wanted to bring up, probably been brought up before. I was out with my 37-year-old son today, and I was asking him when the last time was he had a PSA test or he had a physical, and he said, well, maybe 10 years ago. And I said, well, you have this horrible family history of prostate cancer, and that you really need to establish your baseline as to where you are, so that if something changes, you can know about it early. Unlike your father, who didn't bother to watch until it was already 20. So anyway, he agreed he needed to do it, but we'll see. I didn't pay any attention to it when I was in my 40s. I know that, my early 40s. But, you know, I don't know how many of you know, but my grandfather, my father, my uncle, my brother, and I all had prostate cancer. So anyway, so I have two sons that are, you know, have targets on their back.
So,
Now,
Alan,
did you say?
is there genetics behind that family?
Pardon?
Is there genetics?
Well,
behind?
you would think so. I mean, I was BRCA2 positive, but I don't know.
But was your BRCA is germline too, isn't it, Al?
Yes, I believe so.
So you know,
I had a PSA test when I was 42, which was, you know, that was in 1995, and it, you know, this common knowledge then was started when you were 50. But the doc I had said, well, you have a family history. You need to start it earlier. Well, I had it at 42 and my PSA was 2 and I was told it was normal. So I didn't think anything about it, but I had no baseline at that time. I had no idea whether that was normal or not. And the next time I had one, it was 20 and my Gleason was 9. So.
And when was that? How long after 42 was that?
3 years later.
Yeah.
Whoa.
So, you know, we know that men who do carry a germline mutation should test regularly, like every year. And I think it is really important. Has your son done a germline test yet?
The older one, I think, has got it on his radar that he's going to do it. He's 42. He has a nice steady baseline of well under, I think it's like 0.3 or 0.4, and it's been really steady. And he knows about the genetic testing. I don't know if he's done it yet or not.
Well, both of them can get a test for free. They can do it through Promise, where our Promise man just left us, I think. I just saw Jeff Marchi log off. He'll probably be back in a second. But he's the one who always puts the Promise study in the chat window. But through Promise, they can get a color test for free. Actually, no, I think you have to be diagnosed. If you got a color test, if you tested either with color or Invitae, both your kids can get a test at a discounted rate.
Oh, is that right? I have had the color test.
Yeah, if you've had color, your kids both get it at a highly discounted rate. And I would just order I would call them up, tell them you've got 2 kids, give them the address and send them and have them do it. Because they really need to know, you know, I think of Dr. Pamela Munster, who's BRCA positive, and her son is 22 or 23. He's already tested and he knows he's BRCA positive. And it's so important because it's not just about prostate cancer. There are other cancers for which they are susceptible. Bladder, melanoma, pancreatic. So if they know that they're carrying it, then they've just got to be testing more regularly.
Okay. So by the way, Al,
so anyway,
are you going to have this? Are you going to have the same guy the next time they do the apheresis?
The same person, probably.
Yeah.
Phlebotomist, yeah.
Yeah, the phlebotomist. I think she.
At least the guy who did mine was much more than a phlebotomist. He was a nurse.
Yeah, she's a nurse. She's definitely a nurse. I think that my right arm has had other problems. I think we understand it now. Hopefully it'll go smoother tomorrow.
Okay, well, but putting it back, you had no trouble.
Putting it back was no problem whatsoever. No.
And it won't, remember,
Well,
it won't touch your PSA. That's the strange part of it.
I understand. Unfortunately, I do understand that. Fortunately, unfortunately, the only hang up with with putting it back was that the plane from Atlanta was delayed, so my reinfusion got delayed.
Yeah, that happened to me too.
But apparently, as long as they don't open the box, because there's once they open it, I guess there's a small window in which it has to be reinfused.
Right.
They said that if the box wasn't open yet, that the window hadn't opened yet either.
Okay. Any questions about Provenge or?
Yeah, I have a question for Al. Al, I know you responded well to lutetium. Are you considering more lutetium or Pluvicto?
Well, I don't think it's off the table. I mean, I responded to it very, very well. You know, my PSA went from 60 to 1.4, so that's, you know, that was a huge decrease. But it was not the least bit durable. 1 month later, my PSA started rising again once after I stopped it. So I didn't really have any holiday from it. But the doctor that I was seeing at UCLA, Dr. Calais, said, yes, we definitely have been repeating it. So that may be on the table at some point. I have to deal with a dry mouth issue though. My dry mouth issue is much better now, but after that sixth treatment, the dry mouth was pretty severe. And it has subsided substantially over the last couple of months.
Good, I'm glad to hear that.
I have some input on this. I just want to check, caller number 5, is that by any chance Bob Snyder? You're muted right now, caller number 5, caller 05. Well, you don't know what your number is, but somebody's on the telephone that we haven't identified. I'm wondering if it's Bob Snyder, because he was with us and then he left.
If you're on the phone, could you identify yourself? David, are you on the phone?
No, it could be David. The phone's muted. If it's you, David, your phone's muted, but it could be you. Don't know. All right, let me just tell you a little bit of information. Let me just give you a little bit of update, hot off the press on Pluvicto. The first information is it's very likely that Dr. E will be able to administer Pluvicto as soon as there's sufficient supplies. She's about to sign a contract, which is really good. It's especially good if you're in the vicinity of Houston. It's not so good if you have to travel, but it's always good for the home team because she's a great backup. And so we're very hopeful that she's going to have it available soon. She's also working on a very interesting CAR T trial where the CAR T, which is basically a vehicle to carry T cells to a particular site, is PSMA sensitized. And so we can bring the CAR T directly to cells that express PSMA. And the big concern with CAR T has always been that you can create a cytokine storm, which is a very serious side effects. But if she does this trial, she'll have another drug, which is kind of a switch that can turn off the T cells, which Herb knows about. And Herb's prepping, by the way, for a colonoscopy, so that's why he's here some of the time and he's not here some of the time today. Oh, he's back. And so Herb knew about this CAR T switch, of course. So that's the first Provenge Pluvicto news. The other news is that I spoke today with Telix, who are a radionuclide company out of Australia, and they're the people that are going to be distributing gallium-68 PSMA-11, which was the scan that was being run by UCLA and UCSF that was costing $3,200, and which Al and someone else last week said they'd gotten reimbursement checks for, and that treatment is called Illuccix, like illustrate, Illuccix, and it's going to be widely available. It's available now, and we're actually negotiating with Telix about trying to make sure that you can get that study reread by experienced people at Telix. So if you get it in somewhere like Tulsa, Oklahoma, or Portland, Maine, where the experience isn't there, they don't have the AI ready yet, but they will offer a reread. And what I'm trying to do is to make it easy for anybody to ask for a reread, and so that you don't get pushback from the local reader, either the radiologist or the nuclear guy who thinks they know how to read it, but they may have only read 3 before, because that's the concern that we have. What we do know is that the Illuccix, this PSMA-11, is probably even better than Pylarify and better than the 618. Now, the reason I bring them up is because they're also rolling out a phase 3 study with a radionuclide. I don't know if it's lutetium or not because I didn't ask, but it's with an antibody. And the benefit is it's more focused and it's less likely to bother the esophageal cells. So somebody like Al will be very pleased to hear that. And I asked her specifically, it's a larger molecule cell, so it's less likely to generate side effects. And they'll be testing that pretty soon. They're selecting, I think she said, I can't remember how many sites, I'm not going to say, but they're selecting a bunch of sites across the country to be testing that. I also didn't ask her what the prerequisites are, whether you had to be castrate resistant, castrate sensitive, but we're talking, I mean, my next meeting with her is on July the 11th. So watch this space. That's it. That's all I got to say on the radionuclides hub.
Okay. Got it. I mean, obviously there's a lot of effort in terms of not only what targets to aim for, but also what the nuclide will be. In other words, might have actinium is coming along, and there's a couple of others that are still to be tested. Okay, we're going to move on. Gary Peters, tell us what's up.
Thanks, Herb. I was listening to the recording of last week's meeting when Richard Wassersug talked about the discrepancy in successful outcome rates between those who have a significant other and some sort of family support and those who don't. I was already well aware of that discrepancy, which is really significant because I fall in the category of those who don't have any such support. And so I just wanted to express my gratitude for this group because it is a bunch of guys who really do provide support, and it's very much appreciated.
Well, we're here for you, Gary. I mean, and of course, I'm just up the street if you need help.
Yeah, but you're always in Europe now.
Well, yeah, that is true.
Nice one, Gary. Gary, I just want to tell you, you know, for men like you, it's just an honor and a privilege for us to be able to be here for you, and it's why we do it. And I'm really empathetic. I don't have a significant other, you know, and I get it. And if we, whether you've got a significant other or you don't, that's what we do here. And we don't just do it for the prostate cancer folks. We do it for a bunch of people. And thank you for expressing that. It warms my heart. Thank you.
Yes. So let me go back to Rick's comment about Telix. I just looked at their website and their product development pipeline, Rick. And in fact, they do have their PSMA first generation is lutetium, but they then have one with actinium in the works, which they say is, you know, sort of now getting to be phase 2. So they're active.
Is that small molecule or antibody with the actinium?
It looks to me like it's an antibody.
Uh-huh.
It says RADMAB.
That seems to be
So
what people
I
are
don't know
doing.
what it is, but it's which antibody it is, but it looks like it's an antibody.
She said it was the antibody that's being used at Weill Cornell, if that helps.
Well, was that for lutetium or actinium?
She didn't say. I didn't
Because
ask.
because their antibodies are different for the two different
Okay.
nuclides.
Well, she said it was a large molecule, and she also said the antibody was the one that they're using for at Weill Cornell.
Okay.
Those are the two things. Those are my two. Those for the Sherlocks, amongst you, with your magnifying glasses. Those are the two clues.
Okay.
Gallo at Weill Cornell is doing both actinium and lutetium. He has a trial going on right now with the two combined.
Yeah, well, that's what Steve is doing.
Steve Saft is doing that. He's not on tonight.
No.
Right.
Okay, we'll move on. Gary, we appreciate that vote of confidence. And Jeff Preston, you had something to tell us tonight.
Yeah, I joined you for the first time last fall, and Rick and I had a few emails back and forth. I, in January, had a prostatectomy and waited till April for Dr. Mal. I ended up going to Duke University and seeing Dr. Mal, and thank you for that recommendation. He's been great. But in April, we got another PSA test, and it showed it was 0.21, and he said that if it's over 0.2, between 0.2, I think he said 0.5, it's a gray zone as far as should you proceed further. I just had another one last week, and it's already up to 0.47, so it's going up fairly quickly in 8 weeks, I guess, with doubling. And so I'm going to see about seeing a radiology oncologist, and he's recommended a Dr. Lee, who he works with. He's also in Duke. I'm about 5 hours away from Durham, where they are. And my question really to you is it critical for this next step to go with the same outfit, the Duke folks, or because it's a long way to go, and for me to be away for however duration of time it would take to get the radiation therapy would put a pretty big difficulty on my wife and our home situation here. Is it something I can go up to Asheville, which is close? That I could do. And I've spoken to a Dr. Keene there when I was originally going through this. He seemed like a decent enough fellow. I just need to know whether I should just stick with where I am at Duke and just put up with whatever the drive delay is, or if I had to move there for 6 weeks or however long it is. I'm just looking for advice from you folks.
So Jeff, what are they going to radiate?
To this point, I assume it's going to be in the area where they took the prostate out. It did show that there were margins that were positive, as well as other things that were indicative that might have escaped the prostate. So I assume that it's going to be in that area. I asked Dr. Mal about getting a PSMA to see if that would target it, and he said if you have a PSA less than 0.5, it really isn't very good a test.
Well, but you're close to 0.5.
Yeah.
You're going to
Maybe
be
I'll be
0.5
there.
in no time if this is continuing.
Yeah.
And it seems to me radiating without any idea of what you're radiating or what your targets are or where the disease might be is jumping the gun.
Well, I don't agree with you, Herb.
Really?
I don't agree with you. But I do agree with you that a PSMA test is very smart. And what I would say on that score is that Dr. Mal is exactly right based on the Osprey test.
Okay.
I think I've got it right, the right way around. There was the Condor and there was the Osprey. And one of them was for biochemical recurrence and the other was for initial diagnosis of high risk. Now, the initial diagnosis of high risk, they went down as low as 0.2, and this was for Pylarify. But with the Osprey, they started at 0.5. But given where you are, I think that as Herb said, that there's a really strong likelihood that you get a result. That said, I want to go back to this test that I mentioned earlier on today, this SSTOP, which I'm pretty sure I'm just looking for it as I'm talking. But this SSTOP research, which just came out, strongly recommends that that you, is it the SSP? No, it might be the, sorry, SPPORT. That's the one. I think it's, yes, this is the one. I'm going to put it in the chat window right now. It's the, there it is. It is the SPPORT test, and this is the write-up that Alan Edel did, Tall Alan, some of you know him from the other places. And this is the research that basically says, if you've got recurrence, let's radiate your pelvic girdle, let's give you 6 months of ADT, and let's see how you do. And I think that whilst it's important to see if there is metastasis beyond, I don't, and that's why I would do a PSMA test right now. I think that anybody who's on their game should be following this SSPORT trial that just published. SPPORT. Okay, sorry, I'll put it in again. Now, well, I would start off with Duke, and I would see Lee, and I would say to Dr. Lee that you prefer to do it locally. Can he work with and recommend? Because the problem is that your local guy might not be on top of this SPPORT, and you're going to take it into him. But if Dr. Lee calls him up and says, this is what I recommend you should do with this guy, he's more likely to follow it. Because we do see guys on salvage radiation who use a much smaller field. They use this rabbit ear field, which is kind of like 2 rabbit ears on either side, and they radiate the bed. And then those guys come back after a year and they say, oh, the disease is back again. And it's because they didn't do enough in the first place. And that's why I think this SPPORT is a really important trial, and a trial that you should carry in when you see Dr. Lee or talk to Dr. Mal, and you should get your local guy to do. But I don't think it's that difficult to plan it out. And so I'm sure that you should be able to do it in Asheville.
Okay, good. Okay, well, I'm going to probably set up a video conference with Dr. Lee, and I'll start there, and we'll see where things progress.
Okay, did you get the link in the chat window?
Got it open on my
Jeff?
browser. Yep.
Okay,
Thank
great. And from that link, from Alan's link, you can actually get the paper that's on PubMed. He includes it in there, so you can pull it down, I think.
Okay,
I think.
great.
Okay.
Yep.
Okay.
That's it.
I'm wondering if there's anybody else on the call who's had experience with salvage radiation with recurrence. And, you know, the only other interesting thing I would say is that there was some research, Len will probably remember this one. There was some research last year or the year before that came out and said you don't have to jump in right away at 4 months. If you wait 8 months or 9 months or a little bit longer, the results are just as good with salvage radiation. Len, do you remember that?
But I remember, Rick, is there was a paper comparing adjuvant radiation post-prostatectomy with salvage radiation, where, in other words, adjuvant was given, radiation was given almost immediately after the surgery. And that proved to be no better than waiting till your PSA rose to between 0.2 and 0.5.
Okay.
But I don't recall exactly what you're referring to.
I think that's probably what it was, Len, that I'm thinking of, that you could wait a few months rather than jump right in. But it seems like we're coming to the same place with you, Jeff.
Okay, great. Thank you.
Okay. We will move on.
Anybody, I just want to ask, is there anybody else with salvage radiation or recurrent radiation that has anything they want to say to Jeff, who went through recurrent radiation?
Jeff Markey?
I did it many years ago, and I've made it 11 months before I did mine. Yeah, it was effective. It bought me some time.
What was your PSA when you finally went and had it?
I'd have to look it up, but it was a doubling every couple of months. So it was getting up there above 0.5 or something like that.
No, it'd be key in the next few months before I go to get radiation, if we're going to wait any time, to keep an eye on that PSA every few weeks or every month or something like that.
Yeah, every month is fine.
Okay.
Jeff, you had something to say?
Well, I, of course, that somebody mentioned, I thought had salvage radiation, about 8 years ago. And it was quite successful, at least for 3.5 years. And then, well, because I've got BRCA2, it's not going to go away. So it came back, and Lupron lasted about 3.5 years. And
You're muted.
I when they were talking earlier about having had radiation a second time and considering it a third, it sure hit me over the fact that they said to me that that radiation I got is a lifetime radiation in that area. And, you know, the pelvic girdle is a large area. So, I mean, is SBRT really logical to be done on top of that without having overdone the radiation and having another type of cancer as a result? I don't know, but it worked for me for a long time.
One further question about the BRCA gene. I have not had any genetic testing. Dr. Mal sent my prostate in and got a Decipher mRNA test, which shows high 0.98, which doesn't look too good. But is it worth getting the genetic test as well?
Oh, it's free. It's free. I'll put a link in the chat where the promise, as long as you have prostate cancer, promise wants to have your genetics test checked, and they will even have a geneticist talk to you about the results, and it's all free. So just make sure you don't check the box that says you want to send them a sample of your of your material, because if you do, they won't then send you the saliva test kit. They will tell you have to get a hold of your doctor. So, but it's free to have that test, and they're pretty quick.
You know,
Yeah,
Mr.
I put it
Mr.
in
Marchi,
the chat.
yeah, Mr. Marchi, you slipped up earlier on. You left us for a few minutes. We needed the promise study. Joe Gallo jumped into the breach, and now he's put it in again ahead of you. So,
So you already
yes.
put it in, you're saying?
Yes.
Okay.
Yes, they are.
Yes, you're slow on the uptake today, Mr. Marchi.
But yes, genetic
Just
testing
having
would be
some fun,
important.
Jeff.
My daughter came to see me. I had to step away.
Okay.
Okay. Any other questions? We will move on. Russ Hoover, how are you doing?
Oh, interesting week and a half. I got an email from a Howard Bolinsky asking for information. Why is everybody laughing? I don't know the guy. I put a call into him. I haven't heard back yet. But part and parcel of his email had a lot of links of just very interesting articles about things that I never even thought about. So I don't know what the protocol is behind the scenes, what that is, but I just thought I'd throw it out. Again, I have not spoken to him. He's looking for
Let me explain why
basically
Howard. let me explain why Howard is calling you.
Okay.
Because he wants to interview some people who responded badly to enzalutamide.
Okay.
And you fit that bill, as does David Muslin.
Oh.
And so
Okay.
I figured neither of you would mind talking to him. David
Not at all.
already knows him. Howard does come with a health warning. So I'm just telling you. But you have to take control, and if he's bugging you too much, you just tell him, I'm being recorded here. I got to be careful.
Right. Don't want to say anymore, Rick. Rick, it's
Okay.
enough.
And funnily enough, Howard said he was going to attend this meeting, but he isn't here unless he's masquerading behind caller 05. But
Whatever. Well,
yeah.
I found some of the articles behind his thing kind of interesting, and I wasn't sure what the protocol is, but I thought maybe everybody else might like to have access to those articles. That's number one. Number two, the Savvy Group. Dr., if I can pronounce this correctly, Pooja Marchant. She said hello to Dr. Rick. She's with Bayer Research.
Pooja Merchant. Yeah, hi, yes.
Okay. Anyway, I have been doing stuff on Savvy, and I guess I'm the star pupil right now because I've done probably 15 of these over the last couple months. Now they have a big thing going on, and I'm not quite sure what it's all about, but they have selected me for it, whatever it is. And Dr. Marchand is heading it up, and I'll let you know when I find out what's really going on. Anyway, Dr. whatever her name is said to absolutely say hi to Dr. Rick. Okay, number three.
Yeah.
Number three, Dr. E.
Yeah.
Okay. I live in Florida. I'm currently in Florida. I saw Dr. E in person last week. We had a very nice discussion. I like this lady. And I was telling her about, what has happened with me and Lupron, enzalutamide, and all the things that I've tried that didn't work. And I said, what do you suggest? She said, quit taking them. And I said, what? She said, just stop taking them. She said, we're going to do this. We're going to do some real intensive blood work, and we're going to run you through a Polarify scan, which I'm doing tomorrow morning. And then I'm meeting with her tomorrow afternoon before I leave Texas and go back to Florida. So I'm sort of up in the air as to what she has in mind, but my understanding is that she's leaning toward Orgovyx, is that how you pronounce it? And Nubeqa.
Okay.
But she hasn't said that as a permanent or a positive thing. She said she wanted to get all the blood work and all the test work done, and then she will offer alternatives as to what she thinks will work for me. So that's where I'm at with her. So I don't have any real report there yet. The report will be next week when I get home.
Okay.
Anyway, she also said say hello to Dr. Rick.
Okay.
So
You got
your
all the
reputation precedes you.
Oh my gosh.
Did you,
Does it,
Yeah.
as does it, AnCan's.
it's John, did you quit the enzalutamide yet?
Yes, I did.
'Cause you sound pretty darn good today.
Well, I'll tell you what, I've been off of it for 7 days. The last Lupron shot I got was in February, so my Lupron shot was coming up due now. I didn't take it because I was trying to get in to see Dr. E, and the smallest Lupron shot you can get is 3 months, and I wasn't sure what they were going to do. So I'm really almost a month late on that. But in the last 7 days with no Lupron in my system, and I just quit enza suicide, as I call it, cold turkey. My brain fog has gotten immensely better. I don't have the energy I'd like to have, but I just generally feel better. I mean, I've spent 2 years, and excuse my language, guys, but I was to the point that I didn't give a shit that I didn't give a shit. I mean, there were days I just didn't get out of bed. And it's like you know better, but you just cannot do it. You can't get that 1 foot out of bed. This morning I got up. I'm not ready to run a marathon, but I felt pretty good. The brain fog wasn't as bad. I just feel like a different person this week than I did last. And what she's saying to me, give it a month, let all this stuff flush out of your system, and then whatever she's going to put me on, it will start fresh. So we have a baseline to go from, which makes sense to me. Yep. So that's where I'm at. If anybody has any suggestions, I'm all ears.
I'm happy to hear this report.
Pardon me?
I'm very happy to hear this report.
Yes. Yes.
Me too.
And I just want to, a shout out to Dr. John, because Dr. John's been doing some personal one-on-one support with Russell. And so thank you so much, John, for doing that. And I want to know, Russell, are you chasing Regina around the house?
You should know her well enough by now. Nobody chases her.
Okay.
But anyway.
Russell, I think you have some other very important news to share with these guys as well. Everybody who's on here.
Which is, maybe I'm being naive here, or are you talking about Burning
Well,
Man?
didn't you get some didn't you get something in the lottery? Didn't you?
Yeah.
About Burning Man. Right?
Yeah, well, our thing, just so you guys know where I'm coming from, basically, I'm 78. We've been retired for quite a while. But what we have been doing is we flip houses, 1 or 2 houses a year. We work our ass off 7 days a week for 6 months. And then we travel for 4 or 5 or 6 months, just depending on where we want to go. We've been to all 49 states. We've been to most of the major national parks, et cetera, et cetera. Burning Man was always on our list. We were going to go, then COVID hit. So we haven't been anywhere for 2 years. So this year we decided a little late that we were going to try to get into Burning Man. But Burning Man, for those who don't know what it is a patch of desert in Nevada that is empty except for 1 week a year. And this year there are going to be 80,000 people there for 1 week. No utilities and no nothing. What you take in and you take out. You bring your own food, your own water. There's no money. You cannot buy anything. There are no concessions. But anyway, we hadn't looked at this in years, so we said, oh, let's go buy some tickets. The tickets were $2,000 a pop, plus, getting your vehicle in. And we said, yeah, we're not paupers, but that's a lot of money just for that. And then we decided to read on about it. And down in the real small print at the bottom, you should always read the small print, there was this little paragraph about a poor man's lottery. So we signed up for the lottery about 60 days ago. And you fill out the forms and you show them how poor you are, and et cetera, et cetera, et cetera. And the other night, Regina and I, we have to do this individually. Regina and I both got our notification from Burning Man that we got our poor man's tickets. So instead of spending $2,000 a pop, we get tickets for $225. So we are going to Burning Man. Why? We don't know. But 100 degrees daytime, 40 degrees at night.
Russell, if you move your ass and apply to Jason Turner at Flint's Research, maybe you can earn $200 for an hour, and that'll pay for your Burning Man ticket.
For which thing?
It's right at the beginning of the chat. It's at the beginning of the chat window, but I sent you something earlier today, but there's a research study out there, but they only need 6 people. So
okay, I heard that.
Yeah,
but that's
so
different. Well, the one thing I have that I'm signed up with Savvy for right now, it's an unspecified number of hours. They set up to 8 to 10 hours at $200 an hour. I'll BS with anybody for $200 an hour.
There you go.
Yeah. And the other one you put up with 6 people tonight, I'm signed up for that one.
Okay.
Any other suggestions or thoughts? Or I'm just sort of anxious to see what all the tests.
Well,
about the Irish sweepstakes.
Right.
I think that first of all, you're in very good hands with Dr. E. So that's the first thing. The second thing is that probably you may even be able to consider a drug holiday. She'll figure that out with you. I mean, the one thing with Eleni is she doesn't like to keep men on hormone therapy if she feels they can do without it. And there are a lot of doctors who don't have that philosophy. Funnily enough, the other doc who's very big in that way is Dr. Antonarakis. And they will go easy with you on the hormone therapy. So the chances are you'll have to go back on something, but enjoy. We're just very pleased you're feeling, and you sound so much better. I got to agree with Dr. John. It's great.
Yeah, and again, thanks to Dr. John. This is one of the things I never quite understood is the enzalutamide. You take 4 pills. It's like, does it do the job? Well, yeah, for me, I've been fortunate, I think. The places that showed up that in my bones, most of them have disappeared. The rest of them have stopped growing. They don't show any new growths anywhere. So from a technical standpoint, the therapy worked. But from a living standpoint, I haven't slept in 2 years.
Right.
I haven't done anything in 2 years. It's ridiculous. So I love this lady. She says, quit taking it. I about fell off the chair. Because with all due respect to the people in Florida, I asked them if I could drop 1 pill based on a study I read where the doctor ran a study on 100 guys. They dropped 1 pill. Their PSA and testosterone didn't move, but they felt a lot better. And that lady in Florida just boo-hooed. Oh, no, you can't do that. Then I come to Texas and Dr. E says, well, quit taking them. It's like, wow. So who knows what's coming down the pike? But yeah, again, thank you, Dr. Rick, for Dr. E and the rest of these folks that, you're leading me to. As I get a feeling that what's going to happen here is I'm going to have to come back to Houston like every 6 months for a while to get a good baseline going and stuff like that. But we're going to cheat there too, because I'm at my daughter's in basically Fort Worth, about 5 hours away. So we'll come out and visit them, and then I'll run down to Houston and run back up there. It gives us a good excuse to see the relatives, and also write off the trip to the government,
Right.
because it's a medical thing.
Right, medical expenses.
I know
Yeah,
that.
well, I'm a bean kind of by trade way back, so I understand how that works.
I know a lot of people have been able to stop taking Lupron or whatever, and their PSA has not risen for a while. But I was on it for the first 2 years, and at less than 0.01, I missed my shot by 2 weeks, my 6-month shot. I'd always had a shot. I had a test every month. I missed my shot by 2 weeks. I had a test that week. It was up to 0.6 already. I got my next shot. It stayed down to less than 0.01 for the next couple of years. So you never know whether stopping works or not. I know for me, it maybe it's the BRCA2, but stopping was not a good thing.
Okay, I understand that and appreciate the comment. I got a question there then. I have been on the Lupron shots every 3 months. And for a long time, I thought that was the only thing that was out there, because that was all that was presented to me. I find out there is a 4-month shot and a 6-month shot.
Yeah, and a 1 month, and there's a 1 month
question,
shot
I
too,
guess,
Russell.
And there's a 1-month shot. Now I find that out too, but I think that really I was on the 3-month shot rather than a 6-month shot was, guess what? Money. I wasn't back in the doctor's
No,
office
it's not. That's not clear. I have Russ.
Well, yeah,
I mean, I'm on a 3-month shot at NIH where they don't worry about the money. It's more like control.
Yeah, yeah.
Well,
and
what's the difference? What's the difference in
Russell,
control between 1, 3, 4, and 6?
I'll tell you.
Because
I'll tell you.
at the end of the,
I'll tell you. We know from experience with a lot of guys that we recommend against the 6-month shot, because the problem with the 6-month shot is at the back end in that 5th month, it may not work so well, and it may not control your testosterone. And we've had guys that have not had good results, PSA results or testosterone results at the back end of that 6-month shot. So we recommend that either you get the 90 or the 120-day depot shot. This is with Lupron, because each one of these companies makes a different period of time. And if you want to just test out and see how you're going to do, go for a 1-month shot. But I would, if it were me personally, I would stay away from the 6-month shot. I mean, I did all of mine in 90-day shots. So I don't disagree with the cynicism of, the financial aspect, but I can tell you that the 6-month shot is not a good idea.
Well, I understand.
He said that Dr. Reed said that she was also going to consider the Orgovyx, which is the daily pill.
Yes.
Yeah.
Instead of Lupron.
Dr. E basically said, forget the Lupron, forget the ends of suicide. She said, we're going to get into something else. Probably Orgovyx and Nubeqa, whatever that is. She said, but she's not going to make a final determination until I see her late tomorrow after all the tests and the blood work is back. So I don't know what beyond that she has in mind, or maybe there are different strengths of these pills that I'm not aware of.
They're not. They're basically, Nubeqa is darolutamide, which is an enzalutamide that won't give you brain fog.
She did mention that, and I said, great, I could well do without the brain fog.
And then the Orgovyx is a blocker rather than a stimulant, and it's a drug. It's a pill rather than a shot, and you have to take it every day.
I'm not worried about
So there's
taking it
more,
every.
so there's more control.
There's more control. There's better level of drug in my system at all times, rather than the spikes.
Presumably.
Okay. Do any of you guys have any idea whether these two drugs are going to, and I know this is a very wide question, are going to give me less side effects in general?
They should.
Any history on
Well,
that?
Orgovyx should give you. Orgovyx and Lupron are going to do more or less the same thing. There's some dispute as to whether Orgovyx can have fewer cardiovascular side effects, although the trials we've looked at are really ambiguous. So I'm not sure there's a significant difference. However, it's clear that people prefer darolutamide over enzalutamide in terms of fewer side effects, especially the behavioral ones, especially the ones that affect how you feel. They may not differ in their ability to control PSA.
Okay. Is there any reason to have an electrocardiogram before taking any of these things?
Have you had cardiac problems before?
No, but I have. About 3 years ago, my brother had a problem with AFib, and of course, my roommate, Dr. Hoover, went nuts, so I had to get tested and all this kind of good stuff. And we were on a yearly schedule with my cardiologist where I get an electrocardiogram test, and everything's been good. But somewhere, don't ask me where, I read somewhere that the enzalutamide sometimes affects the heart in ways that they don't understand, and that supposedly the echocardiogram will help show that this is happening, for lack of a better term.
But to think of it this way, you've had a cardiogram while you were on enzalutamide, correct?
I say what?
You've had a cardiogram while you were taking enzalutamide.
I have had 3, 1 before and 2 during.
And so they didn't show any effect.
My
So
cardiologist.
it's unlikely that it's going to show anything now.
Okay, but if I jump into this new stuff, is there anything there that I should be aware of that anybody can?
No, I mean, I don't think there's anything that you haven't experienced, but these are very good questions when you talk to Dr. E again tomorrow or the next day. And bless her, she'll take the time to walk you through it. But I don't think there's anything that we don't know that you haven't experienced. Probably what's going to happen is you're going to do better than you did before, but certainly raise the electrocardiogram with her and ask her the question about the side effects.
Okie dokie. Yeah,
okay.
I mean, it's weird to me because I never had a high PSA. My PSA when this started was 3.18. In 30 days, it went to 0.9 something or other, and it's been on a downward scale. My last one was 0.225. So the drug is working, but it's killing me.
Well, you'll see. I think there'll be a big change, but Dr. E is going to straighten it out for you.
Okay. Well,
so we're approaching the witching hour. So the question is there anybody else that has anything to share with us that I missed? Okay. If not,
well, yes. I mean, I do want to say a few words about Jerry.
Okay.
And I would welcome anybody else on the call if they want to chime in and add. I think probably most of you who are on this call read the reminder. And so so much of what I wanted to say was in that reminder. You know, it wasn't a shock to any of us that Jerry passed away last Wednesday. But it was the reality of it happening, I think, that that was tough for all of us. I spoke Saturday afternoon. I finally got out for a bike ride about 5:30, and as I was no more than half a mile from the house, and the phone went. And I usually ignore it, but I stopped this time and pulled out the phone, and it was Patsy. And so I got to talk to Patsy probably for about 10 or 15 minutes. Fortunately, the kids have all been around all week, and then one of Jerry's oldest buddies pulled into their driveway because they have a huge RV, Jerry and Patsy, and they have all the hookups and everything. And so she said, just come stay here, because there were no RV spots around last weekend being Father's Day. So she's had people pretty much constantly with her. She asked me if I would say a few words about Jerry's prostate cancer journey, because she said to me that most people outside in his world, outside of us, we never saw what he was going through. We never appreciated what he was going through. And those people didn't realize that he was a legend. And as I put in my report, in my reminder, I mean, those were the words of Sue Hensley at Pfizer when I told her, because Jerry and Patsy had been ambassadors for Pfizer, or they talked with Novartis, and everybody loved them. Everybody loved them. I think the biggest thing that struck me with Jerry, other than how incredibly abnormal his disease path was, is that Jerry was a man of huge, huge faith, and had been for many years. I mean, he was pretty much a lay pastor, and had run a grief and bereavement group. Some of you know he lost one child, and he has another child who's in a wheelchair as a result of a serious car accident. And he'd written a book. I think he's written 2 books, and he ran this grief and bereavement. And I really don't think Jerry had any fear of death. But here he was about to go into hospice, pleading with his docs. What else can we do? What else can we do? And Patsy told me the radonc, who he was pretty close to, just broke down in tears. And she said that there isn't anything else, Jerry. And why was it? He wasn't pleading because he was afraid. He was pleading because Jerry loved people. He loved humanity. He loved to spread his love. And he didn't want to go because he had more good work that he felt he could do. That was why Jerry wanted to be around. And for me personally, there's a few people out there who are on the other side who I talk to quite regularly, like Dominic and Rob and Jerry Cornelia. And I'm just adding Jerry Deans to that list, because if I don't know what to do, they're the people I ask. And, you know, some of you know that oftentimes I do what I think is right, and I don't maybe listen enough to other people, but there are some people that I do listen to. And those are the ones on the other side who I ask. And Jerry Deans was one of them. And, you know, I would consult with Jerry often about what to do for AnCan and what to do for this. I mean, remember, of course, Jerry was on the US2 board, had been for years. It really helped to establish US2 as to what it was. And the only reason he never became chair was because he stepped down. He passed up in 2015 because his health wasn't good enough. And that's when Jim Schrate, who was following him, stepped into his shoes and became the chair for several years. And Jerry and Jim were very tight. And Jim now is also somebody a confidant for me. And but he's on the Zero board, so he can't really be on our board or our advisory board as long as he's on the Zero board. So Jim unfortunately can't get out to Mechanicsville, which is just outside Richmond, Virginia, because his wife is having cataract surgery on Friday. But I've asked him to write what he wanted to say, and I'll read that out as well. And, you know, I feel like to some extent, I mean, there's a very big extent to which I'll miss Jerry, but I don't feel like he's gone, and I feel like he's still with us, and he'll guide us, and we'll continue to grow under the vibes that he's sending out already. So, you know, I love you, Jerry, and you were an amazing inspiration, man. I mean, just an inspiration, not to me, to everybody. You were a legend. So that's what I wanted to say. And if there's anybody else who knew Jerry and wants to say anything, probably now's the time. And I will let, when we post this, I'll let Patsy know that if she comes in at around the 2-hour mark, she can hear anything. So if you have anything you'd like to say to Patsy, now's the time to do it.
Well, I mean, I can only say that I didn't know Jerry as well as you did, Rick, but the times that we interacted, certainly he was incredibly inspirational.
Yeah. Yeah, I think Carl's story at the beginning as to just him coming on here right after his brain met surgery. I mean, you know, that's another thing. Nobody lasts 15 months with brain mets with prostate cancer. Nobody. I mean, he went in to see the neurosurgeon, and the neurosurgeon said, "I can't believe you're still with us." It doesn't happen. I mean, you know, we lost Dom in is Len still with us?
Len's gone.
Len's gone. I was going to ask Len how long did it take with Dom, but with Dom it was maybe 3 months, 4 months. With Rob, the same thing. It doesn't happen. Even shorter. It doesn't happen.
At any rate, Rick, I'm going to stop the recording.
Okay, stop the recording. We're done. Anybody else? Last call. Anybody want to say anything?